Very good morning to all of you and happy Ram Navami. And I thank Dr. Rivari sir who has joined ILBS, and this is how we are being able to connect to the larger bodies of the Medical Association IMA. I welcome you all to our institute, Institute of Liver and Biliary Sciences. I look after I'm a microbiologist and I look after the Department of Clinical Virology. We've set up the labs from the very beginning here. So I'm not going to educate you. I know all of you know much more than us, but it will be just a quick revision since we are talking about elimination of hepatitis. So the markers which are important. This is a very basic slide. Hepatitis is liver plus inflammation. There are many causes because very often it is asked that it's only ABC. Sometimes LFT is deranged in other viruses also. What is happening? So liver gets inflamed by multiple things. Yes, those viruses which have a tropism to liver, means they go and replicate inside the liver, are known as hepatotropic. And they are A, B, C, D, E, like the fingers of our hand. Very easy to remember. A and E, acute jaundice. B and C, bloodborne, that is why the red color. D is a defective virus, which requires B as a piggyback. Then apart from that, you will be seeing that the liver function gets deranged in many other viral infections. COVID has also given you a lot of opportunity to see how the liver failure, and these are like dengue, influenza. So any infection, when they stimulate your T cells, what happens is that if the memory T cells are there inside the liver, entrapped somewhere, so the reactivation, and this is known as collateral damage, and you will see abnormal LFT. Apart from it, viruses of the herpes family like CMV, EBV, herpes, they can also give an insult to the liver. Other causes, yes, there are many: alcohol, drugs, parasites, bacteria. So all these can lead to inflammation. So when we look at the biomarkers in the liver disease, we actually divide them into those which are cholestatic damage. So basically ALP. Those which represents your hepatocellular liver damage, they are ALT, AST. And then synthetic function of the liver, because liver is involved in making something, so albumin. And the marker for the HCC, if gradually occurs, is alpha-fetoprotein. So this is a quick snapshot. Again, revising with you all, markers of injury to the liver is by ALT, AST, and they are released from the hepatocyte cytoplasm. Biliary obstruction markers are ALP and GGT. If there is a long-term injury happening to your liver, AST would be more than ALT. And in alcoholic associated hepatitis, usually AST is more than ALT. So a quick snapshot of liver function test, which is the bilirubin, which tells you about conjugation. ALT, AST are markers of actually which are reflecting your hepatocyte damage. And albumin and prothrombin, because the synthesis is abrupted, and that is why they are hampered. So these were about the basic common LFT. Before proceeding for identifying these viruses, as I told you, the talk is on viral hepatitis. So 5 major viruses are there, and they are like fingers of your hand. A and E had been known. They are to cause acute jaundice, typical acute sporadic hepatitis. A more in the children, E more in adult. I'll be showing you things are slightly changing nowadays. Chronicity is only associated chronic liver disease, means persistence of a abnormal LFT for more than 6 months with B, C, and D, but now cases have started coming for E also, so very rare. Transmission is oral fecal contamination in A and E, how it is through perinatal or parenteral transmission. Bloodborne is B, C, and D. There is a very good vaccine for B, we all know, and I hope all of us have taken that vaccine. A also has a vaccine, which is very good, although not there in our universal immunization program, but yes, Pediatric Association and many associations promote it. I'll be talking about it, that why we should take it. E, there is a vaccine, but it is only licensed in China, but yes, people are working on E vaccine. C, you have a very good cure. So you can cure totally, completely, remove the virus from the body. So all these viruses are actually manageable. You can actually treat and cure a patient. This slide has been shown by Sir, that why we have started talking about hepatitis B and C and why it is an urgency, because of the push from the government that we have to eliminate it, and that is why we have to educate more and more, and people like you, where actual patients' footfall is there, we would want that you should be able to treat, diagnose, and put them into the cascade of care as soon as possible. One of the important, this is an old slide, but still where we are lacking, why are we not identifying, is we are not picking them up, we are not testing them. So lack of diagnosis, because B and C usually is asymptomatic. So the LFT derangement occurs once the virus, there is an immune response and the liver cell damage has started occurring. So it will be asymptomatic chunk, and that is why we are missing. Now we can increase this uptake of diagnosis. The first exercise we are already doing, increasing the knowledge and awareness, using the decentralized, so let viral hepatitis not be constrained to big institutes like liver and biliary. It should be as decentralized. It should go to even small general practitioner, medical officers, inside the dispensaries. I think it should be in a very decentralized manner. Pick up cases, put them into, diagnose them, and you can also treat them. Plus, for this, you should have affordable diagnostics available with you. Yes, that is another lacunae. But with COVID, one advantage for the lab people is everybody has become a virologist. Everybody knows what is a PCR. Now, each and every microbiologist can do a PCR, can do any test. So this is a boon, and we should take advantage of whatever COVID has left for us. So actually making more and more molecular testing labs, doing a lab integration, all this will increase the uptake. Now, looking at this problem, the Government of India has launched the National Viral Hepatitis Control Program in 2018. ILBS has been, and myself, Dr. Rewari, we all had been, we had some few small role to play in that, and it has been there, but it runs through the state health mission in each and every, almost all the state. In Delhi, if you say, ours is a state viral hepatitis testing lab, and LNH hospital is the model treatment center. It's on the way of starting. But whom are we actually testing when we say for viral hepatitis in our country? Actually, the testing is done only in case of blood and organ donors. If there is a needle stick injury, then we do. If there is during ANC, we only screen for hepatitis B for a mother, not so for C, and you just vaccinate B and look after B in case of mother to child, but not C. Now with NVHCP that has been rolled out, at least in the government sector, few government sector, you have complete free testing and treatment services available. But in Delhi, it's still, it has to take it a full course. But most of the states have started enrolling where the free testing for B and C, as well as lifelong treatment for B and for C, complete duration is offered under the program. Now talking about very quickly about these viruses and what are the markers we have to look for and learn that so hepatitis B virus, it is it's a DNA virus. It's a partially double standard DNA virus. Important marker are hepatitis B surface antigen, and this is an antigen which tells you about the infectivity, and it's a very good and robust marker to look for an active ongoing infection. There are tests available, card test, ELISA test. Most of the labs are capable, and blood banks which can do. This is the only test you need to do. Once the HBsAg, against the HBsAg, antibody to it is formed, which is anti-HBs. There is a core antigen which is there inside the core of the virus, but this is never released into the blood. So this is not the antigen we are looking for. However, the antibodies which are formed against this antigen, IgM core, IgG core or total core, they are the one which tells you about exposure to infection. E and anti-E used to be a very important marker to monitor, follow up the patients, but now if you ask me which are the important tests I should look for or should tell my microbiologist to have, so it is the HbA1c and HBV DNA, because these are the ones which are required to put a patient on treatment. Once you acquire this virus, you may have acute hepatitis B or a chronic hepatitis B. Acute hepatitis B is mostly when in the adulthood through your horizontal transmission, means from using unsafe injection practices or other methods you have it, but and 90% of the time adults only will have, the body's immune response is good enough that they clear the virus in 6 months time. But mind it, the virus is cleared from the blood, but it also goes and gets integrated inside your hepatocyte. So lifelong the person's liver will have the virus. It only gets cleared in 6 months time from the blood. We call it an acute hepatitis B. It is usually asymptomatic, can have as acute viral hepatitis. Very rarely, less than 1% may present as acute liver failure. Mostly when mother to child transmission of the virus occurs, the child fails to mount or understand that this antigen is a foreign antigen. So they allow the virus to replicate without giving any sign and symptom, and that is why chronic infections occurs from mother to child. This is the basis and reason that why we say that if at birth within 24 hours hepatitis B vaccination is given to child, you can actually eliminate the risk of acquiring any hepatitis B. If we bring 100% vaccination coverage to all the children who are born, newborns, this virus can go. But it is not done so. So that is why these chronic infections, they are known as chronic hepatitis B. They gradually cause cirrhosis to the liver, initially compensated but can be decompensated, and can also cause HCC. Looking at the markers, in acute hepatitis B, as I said, please see, virus gets cleared from the blood but not from the liver. The first marker to appear is HbA1c as early as 2 to 3 weeks following an infection, but then it will subside. Within 6 months it will get clear. Following this, the anti-HbS antibody and to the core IgM and anti-IgG HBC will start forming. E and anti-E also forms during this phase. Now, once the acute infection is over, the patient will be only having core total antibody or anti-HbS. That will tell you that yes, that patient had an exposure. Now, what if it is chronic? Means the surface antigen persists. The body is not able to clear it. The surface antigen will persist lifelong, but yes, during the course it might decline, and so sometimes false negative HbA1c, but patient will have other markers like DNA, core total. So it is always necessary that if any core total antibody positive patients also come, please investigate them, try to know their liver health status, because that could be a marker of chronic and HbA1c is not being detected. So always call the patient on a follow-up. This is a journey of hepatitis B virus. It is the body's immunity. So virus per se is not cytopathic. Virus is not causing the death to the liver. Once the virus comes and resides, it can lie silently, but it is the body's immune response which tries in attempt to clear the virus from the liver, damages. And there is a whole life, all the phases are a balance between body's immunity and the virus. Whichever is stronger wins. May look complicated, but what happens is that there are phases of chronic hepatitis B. The first phase, when the virus enters, is known as immune tolerant. It was the old name. Now it is E antigen positive infection. The virus is dominated. As I showed you here, the immunity is not there. So all the viral markers are high. DNA high, surface antigen high, E antigen positive, everything. But ALT is normal. because the liver death is not happening, because liver cells are killed only by the antibody response which is mounted. So normal ALT but HbA1c DNA. So that is why we are saying that if you want to identify actually infected people, even asymptomatic or general population, screening should be advocated. We should screen for hepatitis B in them. But here we do not treat. Right now the treatment guidelines, I think the next speaker will tell you, if the ALT is normal, there is no treatment, but yes, other precautions, other tests, all are required. Now, this is typically 20 to 30 years. This is the age, if the child has acquired it from the mother, by the time the person is 20 to 30 years, this is the phase of tolerant, immune tolerant, you will see. Later on, once the body's immunity becomes strong, they try to clear the virus from the liver. All the viral markers will be slightly decreased and ALT starts rising. Here the damage has started occurring, so you need to treat. Again, once the immunity controls the replication of the virus goes into a silent phase for many, many years. This can be 15, 20, asymptomatic. And where we detect them, if they go for donating blood, incidentally, they will come out to be hepatitis B surface antigen positive. So this is, or co-total positive. And this inactive phase, virus is there, but immunity has control. Now, immune escape, what suddenly after 60, the immunity of the body declines, or there is a cancer, or you're on any anti-cancer drug, again the virus starts replicating, which we call as the replicating reactivation phase. Again the ALT, and now this time it's a rapid replication. Sometimes the body immune cells win, they are able to resolve, but that resolution of hepatitis B is less than 5%, very, very rare. Usually the damage to the liver starts. So this is the whole, the entire kahani of hepatitis B. Quickly going through these markers, because you guys are clinician, not the microbiologist. HbA1c, as I told you, is a very strong marker. It is the marker to tell you infection. There are many tests available. This is a card test available. This is a conventional ELISA, and now most of the labs are using these chemiluminescence immunoassays, which are very good. So when ELISA used to take a reading based on the light generation, this is on the luminescence, which is a very strong sensitivity. So labs are usually giving results from these clear assays. Now it's been 15, 20 years that most of the labs are using this. Antibody to surface antigen is a marker which clinicians look for, because that will tell you the clearance of the surface antigen. In the natural course, I told you, very, very less. It's a neutralizing antibody, so it gives protection from infection. It appears following, once the acute infection is cleared. It is also seen following the hepatitis B vaccination. So it is the immunity, it is a marker of immunity. And ideally an anti-HBs titer should be more than 10 milli-international units. And this is often a memory T cell, so it's a training immunity. So once you have acquired more than 10, any time in your lifetime, that means your body has been trained to identify any surface antigen. You need not do it each and every year or monthly, but at least once. So I hope all of us are vaccinated by 3 doses of hepatitis B vaccine, and we know our anti-HBs titer, that our body can actually mount an immune response to the surface antigen. Hepatitis B surface antigen quantitation is a very new test, but we have been doing it for the past 15 years in institute. This is a marker by which you can quantitate surface antigen, which can actually tell you how the treatment progression or disease progression. Earlier it was thought that surface antigen quantitation reflects the health of the liver, but now the newer markers are coming up, it is not so, and so the poor correlation is there, because surface antigen, which normally the labs detect, is not only attached to the Dane particle, all the incomplete forms of hepatitis B particles also have the surface antigen. So usually it is in excess. So if sometimes the clinicians ask us that, okay, I've been treating this patient, but surface antigen is not coming down, because surface antigen Treatment targets DNA, DNA becomes negative. Treatment is not targeting surface antigen. It usually takes time for it to become negative, many, many years, and it's always in a huge excess because all incomplete viral particles which also have this surface antigen. We have done a couple of studies where we tried to evaluate significance, although we've been doing, but not so. We could not see that surface antigen is a very, very promising marker by which you can monitor the progress of disease in a patient. Other important antigens and antibodies is the core antigen. I said core antigen is always inside the liver, never released into the blood. It is the antibody. First, it is the IgM type, and then it is the IgG type. IgM type usually seen during the acute infection, but sometimes it is also detectable during the reactivation phase. So it's very, very difficult. A patient who is 55 years or 60 years old, you're seeing first time HBsAg with the core IgM also, it could be a marker of reactivation. So it could be a mother to child transmission and reactivation. It's not looking, if there is no evidence of a transfer of blood product or horizontal transmission, very, very difficult to say that it is an acute hepatitis B infection. IgG is the long marker for hepatitis B core antigen, but very difficult to differentiate IgM and IgG. So most of the labs are giving you results in the form of total antibody, means both IgM and IgG. As I said, IgM is also seen during the chronic infection, so it is better to tell them, and it's a very, very good marker which tell you exposure. If a blood bank is not doing a NAT testing, PCR testing, core total antibody is also another marker by which they can screen for the exposure to infection. E antigen and antibody, yes, it is a marker which tells you about active replication, but now you have more sensitive marker like DNA. So people are not, it's an unnecessary test. If you have limitation of budget and you just want two tests, then HBsAg and DNA. And nowadays DNA also query as per the latest WHO guideline. NT-HBE also tells you that the body is capable of mounting a response. So quite old standard physician and gastroenterologist would also like to see for the seroconversion of E to anti-E to look for an immune response of the body. This is a very simplified, I think my next speaker will be speaking. This is as per the national program, because here we would like to have minimal test and put more and more patient on treatment. So the only lab markers which are required in putting a patient on treatment are doing a surface antigen, looking for the fibrosis, doing a fibroscan or APRI score, ALT, and then DNA, which are actually needed in putting the patient on treatment, which will be told to you by the next speaker. There are few new, so old markers are HBsAg, anti-HBs, and DNA, which is very, very important. There are certain new markers which are coming up. I think I should skip because it's not needed. A word about hepatitis B immunization, since I touched this subject. So hepatitis B vaccine is made up of recombinant surface antigen. So why I wrote this? Because if a person you have tested somebody and HBsAg is positive, always take a history. That person is not recently vaccinated, because HBsAg from the vaccine will also be picked up by your clear and ELISA, so it can be a false positive. Anti-HBs titer tells you about protection, and it should be ideally done 2 to 3 months after you have taken to see for a body's response. More than 10 is a protective titer. And all healthcare worker. Now what in case you have forgotten, you don't know that whether I have taken the vaccination. So idea is that please try to remember, and you should have a documented proof, a lab-based report that your anti-HBs titer is more than 10. If you don't remember, please start with second and third dose, or at least third. All 3 doses of hepatitis B should be given, because that only will give you a long-lasting immune response. Coming to the C virus, it is a RNA virus, very simple. And only thing is that antibody to HCV tells you about exposure. So this antibody is not protective. This is not telling you protection, but anti-HCV is a marker of infection. And RNA, if there is an ongoing infection, that's all. Acute HCV, very, very rare, difficult to see because it's asymptomatic. It's only that RNA is cleared within 6 months on its own, which occurs only in 20 to 30% of cases. 70 to 80%, if HCV is there, it will persist and it will be a chronic HCV infection. Only two important markers, HCV antibody testing, and all antibodies should be put onto RNA testing. Any RNA, put them onto treatment. This is the management guideline. RNA and antibody testing are the only important test. Forget about fibrosis and cirrhosis also. You have to treat any RNA, treat. DA are the real game changers. And what now, you don't have to do on-treatment RNA test. So the drugs are given for 12 weeks. After that, you wait for 12 weeks, and then we do only one viral load test, which is known as SVR12. SVR12, and there's no need to keep on doing RNA test on treatment. Core antigen is also another new marker, which WHO says you should start using it. But we have done few studies, but we did not find it right now cost effective. Genotyping now is not recommended. Earlier, we used to give interferon treatment based on the genotype. It is not recommended. So, core antigen. Now, hepatitis E virus, it is the most important virus which causes acute sporadic viral hepatitis in adults. But recently, we have started seeing a decline in the incidence. It's a very simple virus. This virus actually, again, the virus is there for a short time. The peak of jaundice coincides with your IgM antibody. So IgM assay is the only assay by which you can diagnose. A word about chronic HEV or HEV in immunocompromised. Here, the difficulty to clear the virus, and if the RNA persists beyond 3 months, either in fecal shedding or in blood, then we call it a chronic. It is usually by the zoonotic genotypes of the virus, 3 and 4, not by the genotypes of the virus which cause human infection. Fortunately, we have not seen, only there are 1-2 case report from PGI and AIIMS New Delhi, which say query chronic HEV, but we have not seen in our transplant patients till now any chronic HEV infection. Hepatitis A virus, usually acute, okay. I think I'm done, the changing epidemiology. Just to summarize that, to meet these targets, I think we need to enhance the diagnostics and making the clinicians aware of viral hepatitis testing. Thank you so much.